Hello and welcome to this video on prescribing in vulnerable groups from the Department of Family Medicine at RCSI Perdana. I'm Professor Anthony Cummins. This is an outline of the video. We'll begin with some learning outcomes and then we'll go through in series these different vulnerable groups: children, pregnancy and lactating mothers, elderly, opioid addicts and methadone maintenance program patients, palliative care patients, and then some references for you to read further. The learning outcomes from this video are as follows. You should be able to outline the principles of safe prescribing. You should describe the process of medication review and explain the use of a drug formulary by the British National Formulary and the British National Formulary for Children. You should demonstrate rational, evidence-based safe prescribing in the following vulnerable groups: elderly, pregnancy and lactating mothers, children, opioid addicts and palliative care patients. Let's look first at children. Absorption is variable in children for different reasons. Oral absorption is variable because the pH varies. It's quite high at birth and then it falls. There may be increased absorption of acid labile medicines. There may be reduced peristalsis and reduced gastric emptying. There is generally slower and more unpredictable absorption than in adults, but after a few months these various processes are quite similar to those in adults. Intramuscular injection of drugs should be avoided except for vaccinations and immunizations because there is reduced absorption. The process is painful and unpredictable. Percutaneous absorption of drugs is also poor because the skin is immature. There's little barrier to systemic drug absorption, and also infants, especially neonates, have a very large surface area relative to body weight. Rectal absorption is reliable and it gives assured absorption. It's a good alternative to oral and IM routes, particularly in infants and babies who don't easily take oral medicines. Metabolism is poorly developed until about 1 year, particularly hepatic metabolizing systems through which most drugs are metabolized. This becomes similar to adult levels at about 3 years. Neonates particularly unable to form glucuronides, and glucuronidation is one of the commoner methods of hepatic metabolism of many drugs, so be careful with drugs like morphine and paracetamol. Renal excretion at birth depends very much on gestational age. It increases rapidly, however, reaching adult levels at about 3 months. But in some preterm infants, renal excretion of medicines may be prolonged, and you may require to use extended dose intervals. So what factors should you consider when prescribing for children? Well, first of all, there's variations in size and pharmacokinetics. And the other issue is about compliance and concordance. It's very important to educate the parents and carers of children about drug concordance. And if the child is of an age to understand, then try to persuade the child about the value of correctly taking the medicine. There may be an issue about administration of medicine in schools or daycare. And also there's an issue about the choice of formulation, whether it should be liquid or tablets. Many children can't tolerate tablets. They are quite happy to take liquids and suspensions. Ideally, these should be sugar-free. Most drugs are not officially licensed for children, and so they're prescribed off-label. There may be an issue also about the excipients or the fillers that are used in the production of the physical tablet or capsule, etc. You may need to calculate the dose accurately for children depending on body weight, size, etc. Consent to treatment in children is also an issue. It depends on whether you are in Irish medical care or Malaysian medical care. In Malaysia, the age of consent is 18, but in Ireland, children under 16 can consent if deemed to understand fully. The law in Ireland states that adolescents aged 16 and 17 can consent to treatment, but cannot consent to refusal of treatment without parental knowledge. There's a reference here to the Gillett competency rule that came in 1982, but this refers to the UK and not to Ireland. In the Irish Medical Council's Guide to Professional Conduct for Ethics for Registered Medical Practitioners from 2009, they state that children and young people should be involved as much as possible in discussions about their healthcare. So when talking to a child or a young person, it's important to give them information in an age-appropriate manner, to listen to their views and to treat them with respect. Dose calculation in children is done in three main ways. One is on body surface area, which is very accurate, and it's used particularly for chemotherapy. Also, there may be a dose calculation based on body weight. This is also used for chemotherapy and is also accurate. Then there's a more general method, which is age band recommendation. So, for example, 0 to 6 months, 6 months to 1 year, 1 to 2 years, 2 to 6 years, and then 6 to 12. After the age of 12, the doses are similar to the doses for adults. It's important to point out that the most common cause of error is to miscalculate the dose. In particular, in missing a decimal point could lead to a tenfold increase in the dosage given. Here's a question for you. A premature infant has been prescribed 7.4 milligrams of aminophylline to be given IV for severe asthma. It is available as 250 milligrams in 10 ml solution. What volume of the solution should be administered? Is it A, 0.3 mils, B, 7.4 mils, C, 3 mils, D, 3.4 mils, and E, 0.7 mils? We can discuss the answer to this question and other questions in this video during class. Here's another question for you concerning an infant also. Charlie Flanagan is a 4-year-old boy who attends your clinic complaining of a cough and temperature. On examination, his temperature is 39.5. He is talking in sentences and is clinically hydrated. His respiratory rate is 22 per minute and his pulse is 110 regular. There are decreased sounds in the right lower base, so you make a diagnosis of a right lower respiratory tract infection and decide to commence him on antibiotics. He has no known allergies. Of the list shown here, which is the most suitable oral antibiotic and dosing regimen for him? A. Doxycycline 200 milligrams twice daily for 1 week. B. Amoxicillin 250 milligrams 3 times daily for 1 week. C. Ampicillin 250 milligrams 3 times daily for 1 week. D. Trimethoprim 200 milligrams twice daily for 1 week. And E. Erythromycin 250 milligrams 3 times daily for 1 week. You should acquaint yourself with the formularies available in the British National Formulary and the British National Formulary for Children. It is available at both libraries in Graham Cecil's Academic Centre and at RCSI Perdana Main Library in book form, and also available online through Easy Proxy if you're outside campus, or through the main campus library on the Medicines Complete section. Let's look at prescribing in pregnancy now. It's estimated that up to 99% of pregnant women use prescribed drugs or over-the-counter drugs during pregnancy. 50% of the pregnancies are unplanned, and many women may take medicines before they know they're actually pregnant. The Federal Drug Administration in the US classifies drugs in terms of fetal harm as follows. A. Possibility of fetal harm is very remote. B. Control studies fail to demonstrate risk. C. There's a risk-benefit trade-off. D. There is positive evidence of risk, but the benefits of the drug may make use unavoidable in pregnancy. And X, where risk outweighs benefit. It's of interest that almost 10% of women use a category D or X medication during pregnancy. What about timing of exposure in terms of risk to the fetus? This is an important determinant of risk. It's important to know exactly the number of weeks post-conception. As organogenesis occurs in the first 12 weeks after conception, this is the most vulnerable period. So there's a pre-embryonic period of 0 to 17 days. Then there's an embryonic period up to 8 weeks. And then there's a fetal period from 9 weeks to birth. Most vulnerability is in the first 8 weeks. But even in the fetal period from week 9 to birth, some systems such as central nervous system or genitalia remain vulnerable and may lead to growth retardation, or there may be functional defects. What about exposure close to term? There may be neonatal effects or withdrawal effects in some babies born to mothers who are, for example, methadone dependent. And also delayed effects may be some years after exposure in utero, for example, the effect of diethylstilbestrol. Besides timing of exposure, there are also other risk factors such as the dose, the possibility of polypharmacy, as teratogens may act in a synergistic fashion, and there may be genetic variations in drug metabolism. General principles of prescribing in pregnancy are important to take on board. Only prescribe when necessary. Consider the gestational period. Discourage the use of inappropriate medications or substances. Encourage concordance with necessary medications. Use the lowest effective dose for the shortest possible time. Avoid polypharmacy if possible. And in general, use older, more established drugs whose provenance we know well, and avoid new drugs or recently released drugs. Here's a question for you in relation to prescribing in pregnancy. A 28-year-old pregnant woman at 8 weeks gestation presents to you. She has symptoms of a urinary tract infection, and lab culture confirms the presence of E. coli with more than 100,000 organisms. The laboratory hasn't yet furnished you with the sensitivity report, but due to the clinical symptoms, the GP and the patient feel an antibiotic is warranted. Which of the following is the most suitable for this lady? A. Flucloxacillin, B. Trimethoprim, C. Amoxicillin, D. Doxycycline, E. Piperacillin. Let's look at breastfeeding mothers now. And the underlying principles about breastfeeding you should be aware that almost all drugs are excreted into breast milk. Some are toxic and completely contraindicated, for example, amiodarone or cytotoxic drugs. Drugs that are license-fees in infants are generally less of a concern, and some older drugs may have more information. Herbal medicines may potentially have risks, and also there may be less information about their safety. The most vulnerable infants are preterm infants and those who are small for dates. You should use a regime and a route to minimize infant exposure to harmful medication or harmful effects of medication. So try to use monotherapy and the lowest effective dose where possible. Use more established drugs that have information that they are safe in breastfeeding. Avoid drugs with long half-lives. Avoid long-acting formulations. Feed just before a dose is due where possible, that minimizes the potential harm. And dose just before a baby's longest sleep period also to minimize harm. It's a question for you about breastfeeding mother. A 27-year-old breastfeeding mother comes to you complaining of flu-like symptoms. She's now 6 weeks postpartum. On examination, her temperature is 39 degrees Celsius, and she has a tender right breast with an obvious erythematous streak noted. A diagnosis of acute mastitis is made. Which of the following medication would be the most appropriate for this patient? A. Piperacillin, B. Doxycycline, C. Trimethoprim, D. Flucloxacillin, E. Ciprofloxacin. Let's look at prescribing issues in the elderly. When considering a drug for prescribing in an older patient, often the best drug is no drug. Take a thorough drug history, including not just currently prescribed drugs, but also over-the-counter medications, herbal medications, traditional Chinese medicines, and also illicit drugs. Don't be afraid to ask the question. Even older adults use illicit drugs. Avoid unnecessary drugs. Is a drug really needed? Explore non-drug options. Be aware of the effects of harmful side effects of drugs on quality of life. For example, using non-steroidals for patients with osteoarthritis of weight-bearing joints. Would you be better advised to bring in an occupational therapist and a physiotherapist rather than giving oral drugs that could be harmful? To avoid polypharmacy, treat causes of symptoms, treat illness rather than individual symptoms. That way you will lessen the total amount of drugs a patient has. The more drugs you prescribe, the more likely there will be harm through interactions. Also be aware of an elderly person's comorbidities. Choose wisely and carefully. It's good advice to titrate the dose of drug. Start with a low dose and then gradually up it to the target dose very slowly. An example would be the prescription of bisoprolol or carvedilol for heart failure. You start off with the lowest dose and then you increase it every 2 to 4 weeks. You should have regular medication review with the elderly because they're so sensitive to adverse effects. And the elderly are particularly vulnerable because they get most of the drugs. They get about 45% of all prescribed drugs, and 78% of all prescriptions in the elderly are repeat prescriptions. Your average older adult in Ireland and the UK gets 22 items per year dispensed. And because they take so many drugs, they are 3 times more likely to be hospitalized because of adverse events, and also they're more likely to die because of adverse events. Why is this happening? Well, there are 2 main reasons. One is pharmacokinetic reasons, and the other are pharmacodynamic reasons. Looking at pharmacokinetics, first of all, absorption. This is delayed by comparison to young adults. And then this distribution of the drug in the body is also varied because they have a reduced lean body mass and also reduced total body water. They may also have an increased total body fat and a lowered serum albumin by up to 25%, and this is important in protein-bound drugs. And there may be an increased concentration of protein-bound drugs such as warfarin. Metabolism also, both hepatic and renal, may be reduced. Renal excretion should be assumed to be reduced in the elderly because GFR, or glomerular filtration rate, declines by approximately 1% annually from the age of 40. So you should assume in dealing with an elderly patient that there is some renal impairment already present. Get his knees done and calculate the eGFR. You should have particular care from the renal excretion point of view with the following drugs: digoxin, aminoglycoside antibiotics, lithium and propionamide. Now, pharmacodynamically, there are changes at the molecular and cellular level with age, and these alter the body's response to drugs. There's not a huge amount of data available, but there may be also changes in receptors and so forth. But the overall effect is a diminished response to medication, and therefore likelihood of adverse effects with standard therapeutic doses. Be aware also of the prescribing cascade, which we've covered in another module on medication review, but it's worth going over this again here. Here's an example of a 78-year-old man who attends his GP with hip pain. This is deemed to be due to osteoarthritis, and is given diclofenac and advised to review in 1 month to assess its efficacy. Now, you should know from the medication review class that diclofenac and other non-steroidals in those aged over 65 is not a good choice for 2 reasons. One is because of the GI side effects and dyspepsia and indigestion and sometimes bleeding. But more importantly, nowadays we are aware that non-steroidals in this age group cause cardiac events, both fatal and non-fatal cardiac events. So I'd review 1 month later, he's found to have a raised blood pressure. Without drawing the conclusion that this is related or could be related to the non-steroidals' fluid-retaining property, he is assumed to have hypertension and is put on bendroflumethiazide. Even if he did have high blood pressure, this is not a good choice. The choice should be between an ACE inhibitor and a calcium antagonist. Subsequently, when he returns, he has a raised serum uric acid, and then he begins treatment for gout. This drug is allopurinol that he's given, and this makes him feel nauseated. But this is ascribed to an underlying gastric disorder for which he's given metoclopramide. Metoclopramide delays gastric emptying, but also it has a central effect on dopamine D2 receptor antagonists, so he then develops an acute dystonic reaction, which is misinterpreted as a Parkinsonian feature, but he's now given levodopa. It should be clear that all of these episodes and the consequent prescriptions are incorrect, and this should have been dealt with from the outset by either not prescribing a non-steroidal or stopping it once it had been prescribed and led to the raised blood pressure. Let's look at a medication review for an elderly person. You may remember from our medication review class, as well as looking at the drugs that are here and the doses and the appropriateness of them, you should also consider the drugs that are not present and maybe should be present. So this lady is a frail 78-year-old who presents with her carer to your clinic to get a repeat prescription. Her background diagnoses are congestive heart failure and rheumatoid disease, and this is her drug history. She takes diclofenac 50 milligrams 3 times daily, aspirin 75 milligrams once daily, furosemide 40 milligrams twice daily, prednisolone 5 milligrams in the morning, and digoxin 1 to 5 micrograms daily. So what side effects do you think may present a problem for this lady? What monitoring is needed? Is there a PPI present? And is there a PPO? This is drugs that are omitted but should be present. Again, we will discuss this in class. Let's look at opioid replacement therapy. This is the procedure of replacing illegal opioids such as heroin with longer acting, less euphoric opioids such as methadone. And the aim is that the methadone replacement therapy will aim to introduce a more stable lifestyle with less withdrawal reactions and cravings and less criminal behavior in order to fund the daily use of heroin, etc. And it also may help them to reduce their overall intake and gradually lead to a reduction in dose of methadone and hopefully to stop methadone completely at some future time. Buprenorphine is also used, but the main drug used in opioid replacement therapy is methadone. In Ireland, all patients must be registered on the central treatment list before being prescribed methadone. This is a confidential list available only to doctors and pharmacists. Each patient is assigned to a named doctor and named pharmacist. And every person participating in the program has a drug treatment card which is valid and updated on an annual basis. Methadone may only be prescribed in a specialist prescription form, and the prescriber specifies if the doses should be supervised by the pharmacist every day, some days, or not at all. Please now write a 7-day prescription for the patient below who's just been seen at the methadone maintenance program. He's a regular attendant, so this is not his first prescription. He normally takes 80 mils of methadone, and that's 1 milligram per mil concentration. He takes this once daily. He takes no other medicines, no illicit drugs. He's had a urine tox screen which has been clear. His details and yours as the prescriber are as shown below. Let's look now at palliative care patients. When writing a control drug for a palliative care patient for pain relief, there are certain essential legal requirements. First of all, the prescription must be in ink. You cannot write these in pencil. In fact, you can't write any prescription in pencil. The prescription must include the prescriber's name and signature. It must be dated by the prescriber. It must include the prescriber's clinic address and phone number and the medical council registration number. The prescriber must specify in their own handwriting the name and address of the patient, the dose of the drug, the form in which it's given, either tablets or liquid, and the strength, So for example, in the previous screen on methadone, it was 1 milligram per mil. And finally, in both words and figures, you must enter either the total quantity or number of doses to be supplied. So for example, if the total quantity is 200 milligrams, you would write it as such: TWO space HUNDRED space MILLIGRAMS. Here's a sample prescription from a Dr. Isnin Azhar from Hospice Putrajaya, 123 Jalan Putrajaya Utara Putrajaya 43100, and telephone number 0345671234, and medical council registration number 012345. It's dated the 23rd of September 2016, and it's for a patient, Mr. Wong Kin Fon, of apartment 12A, Jalan Setyakasi, Damansara Heights, Kuala Lumpur 56000. And the prescription is for morphine sulfate tablets, 10 milligrams, and in brackets TEN, 1 tablet, that's ONE, twice daily, and then 14 in number and in words, FOURTEEN, tablets, and then signed by Dr. Isnin Azhar. Here's another question for you. Again, that's Dr. Isnin Azhar. You've just seen your patient at the hospice OPD. Her name is Nurul Binti Muhammad, and she lives at apartment 12B, Jalan Rajachulan, Kuala Lumpur 50300. She has terminal ovarian cancer. Now, she normally takes long-acting morphine sulfate controlled release 40 milligrams tablets twice daily, but her pain has worsened over the last week, and you've agreed to increase her morphine sulfate controlled release to 60 milligrams twice daily in order to control her pain. In addition, because this may not be sufficient, you prescribe a shorter acting morphine sulfate for breakthrough pain. This may be given up to 4 times daily, and the dose of the shorter acting morphine is calculated as 1/6 of the total daily dose of the controlled release morphine. She also has bone pain, for which you want to prescribe diclofenac 75 milligrams twice daily. Please now write the prescriptions outlined for this patient, and we will discuss this in class also. Finally, here are some references for you. The Oxford Handbook of Palliative Care, the current 4th edition, has a section between pages 1028 and 1047 on prescribing, and particularly prescribing in these vulnerable groups. And there's an online link through Easy Proxy for the online edition just here also. There's also a quite extensive section in the Oxford Handbook of Palliative Care on pages 215 to 298. And in Quick Medicine app, if you type in the word prescribing, you will get pages on prescribing in pregnancy, on rational prescribing, and prescribing controlled drugs. Elderly prescribing is in a different section, and you get it by putting in the search term drug therapy in the elderly. And finally, a textbook of general practice by Anne Stevenson has a section in chapter 6 on prescribing in general practice, and particularly it focuses on prescribing in special groups in pages 123 to 126. Thank you.